It gives me great pleasure to be with all these distinguished speakers, and it's very difficult to speak after them. And I will try to simplify the things as much as possible. So we'll try to simplify the things after all these wonderful data that we heard, but we need to collect this data and sum it up and simplify it. So artificial cycle is probably the most common first-line treatment in most ART cycles for preparing patients for FET transfer. It is a patient-friendly protocol because it's very minimal monitoring and allows easy scheduling, which is also friendly to the center and with a very decent pregnancy rate. Moreover, it is a simple protocol, especially in the era of Corona, when we are trying to minimize the monitoring visits. Simply, somewhere during the menses, we start our estrogen therapy, then after reaching specific criteria, we will start our progesterone therapy. We will continue with both of them till the pregnancy test, and if the case is pregnant, we will also continue till at least 10 weeks, as we will tell here. Okay, but it's not that simple, and there are some unanswered questions that we need to take into consideration. First of all, when to start your estradiol therapy? What is the dosage and the formulation? What is the minimal and the maximum duration? And when to start progesterone and when to transfer after starting the progesterone therapy? We'll get the guidance of this very elegant review by Professor Mackens about reviewing the frozen embryo transfer, the optimal endometrial preparation method and timing for embryo transfer. Regarding the onset of therapy, estrogen therapy is not only used to induce endometrial proliferation, but it can also be used to suppress spontaneous follicular growth. Most centers start estradiol therapy between day 2 and day 4 of spontaneous or induced cycle. However, day 1 estradiol can be started, it's early start, but the aim is this profound inhibition will inhibit spontaneous ovulation as well as decreasing the incidence of premature progesterone rise. Regarding the duration, we heard it very elegantly from Professor Bedawi, but most centers empirically supply estrogen for 14 days to mimic the natural follicular phase of the cycle. However, earlier studies by Navot et al. Found that 5 to 7 days are quite enough to achieve pregnancy, but later it was proved that this too short estrogen therapy may lead to high miscarriage rate. So it's proposed that 11 and up to even 40 days is enough and will give you the best reproductive outcome. 40, of course, is too long, but it was reported that cases that we didn't achieve adequate endometrium after 2, 3, 4 weeks, even extending to 5 and 6 weeks, there are pregnancies reporting after this too long estrogen therapy. Route of the administration, orally, vaginally, and transdermally, or are equally effective, and you can use whatever you want, whatever you're available in your country, and also according to patient preferences, and this is supported by a large meta-analysis. The dosage, most centers use the 6 milligram daily dose, but some start with 8, and some start gradually, starting from 4, then 6, and may reach 8 or even higher doses by some centers. But the step-up protocol, which is aiming at mimicking the natural cycle of no added values, and it didn't improve pregnancy rate as reported by multiple investigators. Regarding the monitoring, we are all talking about ultrasound day, especially in the presence of Professor Gaafer. Okay, definitely monitoring is an ultrasound monitoring, and measuring endometrial thickness is a must. And the aim is not just to measure the thickness, but definitely to reach that laminar appearance, the perfect appearance that we all get confident with. But also the ultrasound benefit us to exclude the presence of pre-ovulatory follicles, presence of corpus luteum, and also to make sure that the endometrium is not echogenic. Endometrial thickness by Tuchi said the optimal is from 9 to 14 millimeters, but as mentioned earlier, in a very large study, it was found that in frozen embryo transfer, 7 millimeters or more is quite adequate, but in fresh transfer, we need at least 10 millimeter or more. Some up to give an extra HCG dose on the day of starting progesterone, but actually this is of no value. The hormonal monitoring, there is a very limited information regarding the need or the benefit of hormonal monitoring. Some measured the final estradiol, some measured the LH, but it didn't improve the outcome. However, measuring progesterone at the end of the estradiol phase may be very efficient because 2 to 7% of non-down-regulated cycles will have escape ovulation and premature progesterone rise may occur, and this is detrimental to the result. So you may think of measuring progesterone before starting your supplementation. Regarding the timing, and it is always a $1 million question, when to transfer after starting your progesterone therapy, and this question was asked several times in this discussion. We say that in a study of more than 1,100 cycles, they tried to transfer day 3 embryos either on the 3rd day or the 1st or the 4th day of progesterone, and the blood cyst on the 5th or the 6th day of progesterone. And they found equal pregnancy rates among both groups. So it looks like we are having 1 day to move in and out within 1 day, and this was about the plantation window that Professor Gaafer was telling us earlier in this session. That's not about what we'll talk about 12 hours, maybe you are talking about 2 or even 3 days. In a Cochrane review that was done around 10 years ago, they concluded that if you start progesterone on the day equivalent to the oocyte retrieval or even 1 day after, you will have a very good pregnancy rate. But if you started earlier than this pursued day of oocyte retrieval, you will have a lower pregnancy rate. Randomized controlled trials that was done a couple of years ago found that compared to transferring blood cyst after 5 or after 7 days, found that the shorter protocol is better. It was not significant change, but the trend is that the shorter protocol was better. Mackens in his review made this very elegant figure that found that he should have a theoretical OR day. This theoretical OR day is the day you start progesterone, and it named it day P+0, and this is the first day of progesterone. And he found that best result can be achieved by transferring on the 5th day or the 6th day. So he gave us 1 day in and out. But if you transfer out of this range, you mean too early or too late, you will have what we call a dysynchronization in endometrium. Dysynchronization may lead to clinical pregnancy rate, but will have a high miscarriage rate, and your ongoing pregnancy rate will be decreased. So to sum up, the optimal day for FET is on the day of embryonic age +1. So day 5 embryos is transferred on the 6th day. Transferring 2 days before or after this will lead to high early pregnancy loss. And thank you.
Okay, Sherif, thank you very much.
Thank you, Dr. Hassan.
Thank you very much for a very, very good presentation. And I will state some questions before asking Dr. Seriously, thank you. I will state some questions Sherif can answer, or Professor Gaafer, until Professor Sabri will ask a question. I think that afterwards we'll go to Mahdi. So the question is, endometrial compaction evaluation by 3D ultrasound can give more data. This is for Professor Gaafer. Bob?
The mic, Professor Gaafer.
There we go. Sorry, I was on. I was muted by the host. I don't know. It may be that 3D ultrasound would be much more accurate because you get a picture of the entire endometrium. We don't have the facility to do that routinely on every patient, so I can't do that right now. But it's a good idea, I think.
Recurrent failure of compaction. What do you do? And do you think that endometrial biopsy could be beneficial in these occasions? Recurrent failure of compaction. Do you see this?
Yeah, so we see recurrent failure, and the bottom line is patients who don't compact still get pregnant, just with a lower rate. So if we see recurrent failure of compaction, we will go ahead and do a transfer. but we're trying to in the first 1 or 2 cycles we aim to get compaction if possible.
You've already answered this, but I'll say it again. Do you prefer decrease estrogen dose before start progesterone, or in some cases stop estrogen completely?
Yeah, once we start progesterone, we always lower the dose, and sometimes I'll remove it completely.
With no spotting and no problems, right?
No problems.
Okay.
Actually, it was shown many years ago by, I've forgotten his name, but he took out the corpus luteum and just gave progesterone, and the endometrium was perfect with no spotting. Luteal phase was normal.
Infertility and sterility, preferring intramuscular progesterone in the luteal phase support over vaginal progesterone. This is for Professor Gaafer and for Professor Sherif.
Professor Sherif, why don't you take it?
Yes, there are few publications that mention that intramuscular progesterone is better in HRT cycles to maintain a high blood level, and also a stable blood level, because progesterone doesn't give that high blood level and it is always fluctuating. So there are some reports and the fertility sterility paper with at least 1 injection every 3 days. This is good evidence. And we are actually, this is our practice. We are giving at least 1 amp every 3 days or every other day. This is our practice. But I would like to hear the opinion of Professor Gaafer, please.
So we do IM progesterone plus or minus vaginal progesterone for the 6 days. But once the embryo is transferred, we give the patients the option of switching just to vaginal if they don't like the IM, if it hurts too much. Or we go to every 3 days like the Shady Grove paper. So I think we give the patients the option if they don't like the IM to use vaginal. I think endometrium twice a day like they used at Shady Grove is not a big enough dose vaginally. So we use endometrium 3 times a day if they're just using endometrium, or we use crinone twice a day vaginally if we're stopping the IM.
Did you try
any problem if you continue estrogen for 10 weeks till you get the...
Sorry, repeat, please.
Did you try the subcutaneous?
Is there any problem? Yeah, Sherif.
I couldn't hear the question.
Did you, the subcutaneous progesterone, did you try it?
No, we don't have it available in Canada yet. I would love to have it. I think that would be great.
We'll send you a box.
Okay.
Okay. So before we move, Professor Gaafer, how many days of progesterone are needed before you start first seeing compaction?
We see it as early as 3 or 4 days. But we don't check now till 5 days because we want to make sure that there's a
is it dose related?
I don't know. Could be.
Is it dose related of progesterone, related to dose of progesterone or serum level of progesterone?
I think it probably is, but we haven't tested that specifically.